of cells which constitute this blood retinal barrier. There is increase in the transendothelial support. There is increased permeability. That's because of the activation of VEGF. There is release of pro-permeability mediators, and there is also regulation of pigment epithelial derived factor and other anti-permeability factors. There is blood retinal barrier disruption, which I had shown initially. There is loss of pericytes, loss of endothelial cells, and RP dysfunction. There is inflammation, which is like there is increased leukocyte to enzyme interaction and trapping. There is increased production of reactive oxygen species. There is activation of immune cells and release of pro-inflammatory mediators. And definitely there is a Muller cell as initial normal retina. That in diabetic there is the change in this Muller cell function, which regulates the retinal homeostasis. It maintains the intra-extracellular fluid balance. We saw how these aquaporin channels are important in managing that, and it also modulates the inflammatory response. This is a short video which tells exactly what happens in diabetic macular edema.
This imbalance causes fluid to accumulate in the retina, resulting in intracellular and extracellular edema. Hyperglycemia causes oxidative stress that initiates activation of the retinal glial cells to produce a number of inflammatory cytokines, including interleukin-1 beta, interleukin-6, TNF, and also VEGF. The upsurge of these cytokines attracts more cells migrating into the retina. Activated microglial cells proliferate and migrate into the subretinal space. As a result of abnormal transcellular channel formation in the diabetic retina, transcytosis of activated microglial cells is impaired and leads to accumulation of cells. The trapped microglial cells continue to produce inflammatory mediators that further amplify the inflammatory response and ultimately leads to disruption of the inner nuclear layer and neuronal cell death. Concurrently, the upsurge in inflammatory mediators and oxidative stress leads to dysfunction of the homeostatic control mediated by Muller cells. Cur4.1 channels in the Muller cells are downregulated, leading to reduction of transportation of potassium ions from the Muller cells. Continued uptake of potassium by Cur2.1 channels and osmotically coupled water molecules causes the cells to balloon, leading to intracellular edema and a loss of function of the cells. The intracellular swelling, edematous cyst formation, accumulation of extracellular fluid, and damage to microvessels may result in neuronal degeneration and photoreceptor loss. In addition, altered tight junctions of the RPE cells that can occur in the diabetic retina may cause subretinal fluid to accumulate as a consequence of Starling's law. Microglial cells secrete cytokines, chemokines, and neurotoxins in response to endogenous triggers in the degenerating retina. These increase capillary permeability and further amplify the inflammatory response. Continual dysfunction of the blood-retinal barrier allows leakage of fluid, proteins, and other macromolecules to leak into the retinal extracellular space, resulting in extracellular edema and macular thickening.
Morphological changes which happen in diabetic edema causing the fluid to accumulate, and we saw that there is a role of cytokines. So people have tried looking at these cytokines in aqueous or in the blood. We did this study to try to look at cytokines in the vitreous reflux. Once we give an intravitreal injection, the reflux which comes out, we tried measuring these cytokines to look what type of cytokines are actually involved in macular edema. We know anti-VEGF is a first-line management in diabetic macular edema. So eyes with DME, definitely we know that there are a lot of studies which have shown that the VEGF levels are significantly higher, and this VEGF induces the increased permeability. We also know that in proliferative diabetic retinopathy, VEGF levels are several times more higher than a DME, but not all patients of proliferative retinopathy have diabetic macular edema. That means there are other non-VEGF cytokines also, which probably are involved in the pathogenesis of diabetic macular edema. So this was a study where we tried looking at this reflux and measuring nearly about 28 cytokines. We had patients with no diabetic retinopathy, we had patients with center involving DME, and those with high risk proliferative retinopathy. And what happens to VEGF? So definitely VEGF was highest in patients with proliferative diabetic retinopathy. It was high in DME too, definitely more high in patients with proliferative retinopathy. However, if we look at other cytokines, so these are the cytokines which are common between PDR and DME, and these are the cytokines which were nearly two-folds more increase in more than 50% of cases as compared to controls, meaning that is no diabetic retinopathy. And you can see there are a variety of inflammatory mediators which are involved in diabetic macular edema. So, what contributes to development of DME? We saw what are the morphological changes or anatomical changes which happen, which leads to DME. We also saw that there is increase in the cytokines, both VEGF and non-VEGF mediators, which increase in diabetic macular edema. So, are there different retinal phenotypes which have diabetic macular edema? Meaning, can I predict seeing a patient whether he will develop DME or he will progress to a proliferative diabetic retinopathy? And this was a work which was Professor Nawaz, a very good work where he tried looking at microaneurysm turnover rate and the central retinal thickness and trying to classify whether we can classify patients who have more chances of developing DME. And what he found, the phenotype C, which has a very high rate of microaneurysms with or without an increase in the central retinal thickness, they had odds of nearly nine times more risk of developing diabetic macular edema, meaning there are certain phenotypes which are more prone to develop DME. Uh, there are other evidences which we have gathered over time from these epidemiological studies, which tell us again some risk factors for diabetic macular edema. And this was from one of our epidemiology study where we found that the risk factor for development of DME, it is systolic blood pressure, anemia, and those for patients of DME means those who had diabetic retinopathy but no DME. And on follow up, this is 4 year follow up data, and it was increase in the serum cholesterol. So definitely, one, there are certain individuals who are more prone for DME. Second, there are other systemic factors which play a role in DME. Uh, there are now emerging evidence that there is also some role of gut microbiome in diabetic macular edema, and this is one of our recent where we tried finding an association between gut microbial abundance and sight-threatening retinopathy. So we had patients again with diabetic retinopathy without with many years without diabetic retinopathy, and those with macular edema and those with proliferative retinopathy. And this is the microbial abundance. So what we are trying to look at is the phylum level. And you can see this is across all the samples. It's and of them, if you look at the two important phyla, there is change which is happening in controls and cases. So cases that meaning sight-threatening diabetic retinopathy have more abundance of bacteroides species, whereas controls, those who didn't have diabetic retinopathy, there was a higher abundance of firmicutes. When we tried looking at this ratio called as BF ratio, bacteroides to firmicutes, definitely there is a difference between cases and controls. Those with sight-threatening retinopathy had a higher BF ratio as compared to those who didn't had retinopathy. And this higher BF ratio was because of diabetic macular edema, not because of PDR. So the increased BF ratio or this increased bacteroides reduced firmicutes is mainly happening in DME. And so we also tried looking at a cutoff. So probably a cutoff of 1.05 of this ratio can demarcate people who have DME versus no DME. Now, why this is important is because those who have this gut dysbiosis, the bacteroides release these endotoxins and lipopolysaccharides, and they trigger innate or a natural immunity. There is inflammatory pathways which get activated, leading to diabetic macular edema. Again, one of the clue that probably inflammatory mediators are involved, and this is one of the mechanism which over years we'll be knowing more about this gut microbiome and its role in diabetic macular edema. So, if you look at pathophysiology of DME, so there are morphologically susceptible phenotypes of DME. There is some emerging role of gut microbiome playing a role. Then we have, yeah, one, two.
Okay, lovely.
Yeah. So coming back to this, I think I lost the slide. So if you look at the overall physiology of diabetic macular edema, there are morphologically susceptible phenotypes of DME. There is some emerging role of microbiome in pathogenesis of diabetic macular edema. We know there are a couple of these risk factors which have been shown by many of the epidemiological studies for both presence and progression of diabetic macular edema. And all these together cause this dysregulation of homeostasis, which I had shown in those two videos, the normal retina and the retina with diabetic macular edema, all ultimately culminate in formation of diabetic macular edema. Yes, cytokines probably give some about the role of inflammatory mediators versus other angiogenic factors in pathogenesis of diabetic macular edema. 1 minute. So, thank you very much. I'd be happy to take any questions.
Thank you very much, Rajiv, for that excellent talk. Pathophysiology in macular edema is really an important issue. In particular, you've highlighted the role of cytokines, and this will be picked up by our second speaker, Dr. Gopal Pillai, who will be giving us some insights into the proteomics of refractory diabetic macular edema. Now, we're very happy to welcome Dr. Pillai, who is professor and head of department of ophthalmology and chief of the vitreoretinal services at the Amrita Institute of Medical Sciences and Research Center in Cochin of India. So welcome Dr. Gopal Pillai, please, Gopal.
Thank you very much, sir. Thank you very much for the kind introduction. So I would be speaking today on cytokine release in refractory diabetic macular edema. And I'm sure that there will be some overlap with Dr. Rajiv Raman's talk, and I beg your apologies for that. Yeah. So these are my disclosures. And as you know, pathogenesis of DME includes breakdown of the blood retinal barrier, increase in the vascular permeability, loss of pericytes and endothelial cells, altered retinal blood flow, all which was shown by Dr. Rajiv Raman in a beautiful animation. And along with this, there will be a lot of inflammation, retinal hypoxia, accumulation of fluid in the retinal layers, leading to thickening and disruption of the normal retinal architecture. So the treatment of DME about 20 years back had laser photocoagulation, even steroid treatment with triamcinolone, vitrectomy, etc., till the factor called VEGF was identified as a major pathogenesis of DME. Now, if you look at targeting VEGF in DME, intraocular anti-VEGF agents are quite efficacious and show very favorable soft safety profiles in diabetic macular edema. However, response to anti-VEGF treatment is variable, and many patients do not improve even after several injections. They are called recalcitrant diabetic macular edema, and several factors, including increased VEGF and inflammatory cytokines, increased leukocyte chemotaxis and adhesion to the retinal vessels, and exaggerated inflammation, are often said to be the causes. Anti-VEGF agents reduce vascular permeability by acting almost exclusively on the VEGF receptors. In addition to VEGF, many other inflammatory cytokines and signaling pathways are also implicated in the pathogenesis of DME, as said by Dr. Rajiv. Now, if we come to recalcitrant diabetic macular edema, different authors have actually classified them differently. But generally, despite treatment, patients with recalcitrant diabetic macular edema experience poor visual gains, low reduction of macular edema, persistence of macular edema, or resistance to treatment. But when we look at poor visual gains, there may be a lot of anatomical factors which would lead to poor visual gains, like an alternate problem, like an optic nerve problem, or a scar, or outer retinal damage, or even a hard exudate plaque. Actually, low reduction of macular edema and persistence of macular edema are the key factors which cause resistance to treatment in recalcitrant diabetic macular edema. So, Dr. Rajiv had talked to us about the cytokines in DME, and this is a hypothesis where hyperglycemia causes accumulation of the advanced glycation products, oxidative stress, and PKC overaction, which would actually cause increase of inflammation, and that would again cause VEGF and PIGF. And on the other side, cause loss of endothelial cells, pericytes, impairment of blood flow, hypoxia, both of which increase the VEGF receptors and the blood retinal barrier breakdown to form the diabetic macular edema. So, now, I had done a study looking at significance of VEGF and identification of responders and non-responders in ranibizumab-treated DME, and tried to characterize the responders and non-responders based on the cytokine responses. And the study was conducted as a part of investigator-initiated trial funded by Novartis. So the objectives were to monitor the VEGF levels in response to clinical treatment and to identify responders and non-responders to anti-VEGF therapy and to characterize their cytokine signatures. So here the study, there were 40 patients who were enrolled. The patients were administered intravitreal ranibizumab for 6 months. The first month, second month, and third month injections were mandatory. And then fourth and fifth month, we had looked at a PRN basis. So if the macular edema was more than 300 micron, we had injected. And if the edema was less than 300 micron, we had observed. And the sixth injection was mandatory. So 1, 2, 3, and 6 monthly injections were mandatory, and 4 and 5 were in the PRN basis. We had looked at VEGF and cytokine levels using ELISA and the cytokine bead analysis using flow cytometry on each time when the patient was injected. And when the patient was not injected, we could not get an aqueous sample. And OCT and visual acuity, best corrected visual acuity were assessed, and then statistical methodologies were used. Now, how did we categorize responders versus non-responders? We looked at only the macular thickness and not improvement of visual acuity as such. So macular thickness, if it reduced more than 40% in the first 3 months, or the second criteria was macular thickness had normalized in the first 3 months, or the third criteria was if only the 4 mandatory injections were required in 6 months, then we said if all these 3 criteria were met, we said that they were responders. And if all the 3 criteria were not met, then we said they were non-responders. That's how we categorize the responders versus non-responders. This is collecting of the samples and using minus 70 degrees to store. And this is the change in the VEGF levels in the aqueous humor in patients with diabetic macular edema. On the left side, you can see the slide where the baseline VEGF levels were somewhere around 900, which reduced picogram per milliliter, then microliter. This reduced to about 300 by the first month. And as you can see, the 1, 2, 3 injections were mandatory, and you can see that the VEGF levels remained low. And the fourth month and the fifth month, we had to inject only if the edema was more than 300 micron. So the 3 months and the 4 months were those patients. And you can see that by fourth month, there was an increase in VEGF. And this is the mandatory sixth month injection where you can see that the VEGF is slightly higher than what it was at the second and third month, but significantly lesser than the baseline. And the right side shows the change in VEGF from baseline to month 6. Looking at visual acuities, you can see that from about this is a logmar visual acuity, and from about 0.45, it reduced to about zero point 0.3, which is about 3 lines of improvement. And that's the average visual acuity change from baseline to month 6, about 3 lines improvement. And this is macular thickness. Again, from about 500 microns, it fell down to somewhere around 300 microns steadily, and that's a change in the central macular thickness. Now, when we categorize these patients into responders versus non-responders at the end of 6 months, by using the 3 criteria that I mentioned before, you can see the change. This is the blue is the responder, and the red is the non-responder patients. You can see that the visual acuity was worse in the non-responder, and you can see that the visual acuity, that's the left graph, you can see that the visual acuity improved, but the improvement of visual acuity in the responders were much, much rapid than the non-responders. Looking at the central macular thickness, there was a baseline difference between the central macular thickness of the responders and the non-responders. That's the second graph you can see. And the reduction in thickness of the macula was hardly anything in the non-responders, where it significantly reduced in the responders. Now, looking at a very interesting thing in the change in the VEGF levels, you can see that they had almost equal VEGF levels to start with, and both the people's VEGF levels reduced significantly with injections. In fact, the reduction of VEGF levels was more in the non-responders, and then we had injected only the patients who are non-responders. That's the fourth month and the fifth month injections. So these are the wedge of the non-responders. And in the sixth mandatory injection, we could find that the patients who had responded very nicely, who had missed 2 injections, had a significant rise of VEGF back to the baseline, whereas the patients who continued to get the injections had a very low VEGF value. So what does this tell us? This tells us that the patients who are non-responders are not becoming non-responders because their VEGF levels don't fall down. It is because of some other factors. And those some other factors were the things that we are going to look at. This is a grouping that we had done. So we had grouped the VEGF into low VEGF, medium VEGF, and high VEGF. Low VEGF 150 to 600, medium VEGF 600 to 1750, and more than 1750 was high VEGF. And when we looked at the behavior of these 3 groups, you can see that the brown graph, this is the VEGF levels. There was a significant drop in VEGF even in the high VEGF category. But by the time they reached the fourth month, there was a significant increase back of the VEGF levels. If you looked at central macular thickness or best corrected visual acuity, you can see that the very high VEGF level patients had a worser central macular thickness and a worser visual acuity to start with, and they actually reduced in macular thickness more than the other groups, telling us there was some macular ischemia or foveal atrophy in those patients. Whereas the best corrected visual acuity, you can see that they improved, but they were about 2 lines lesser than all the other groups. So now looking at the cytokine levels in responders versus non-responders in these groups, we had looked at about 12 cytokines, and these were the 4 or 5 cytokines which were significant. This is the interleukin 6 levels, this is the responder group, and this is the non-responder group. In the responder group, you had a slight increase in the IL-6, whereas you can see that, but by the 6th month, the IL-6 has dropped so much. Whereas in the non responder group, the interleukin 6 shot up by the end of 6 months. We should understand that these are patients in whom they had got 6 injections in 6 months, and despite that, the interleukin 6 was increasing here. Now, regarding IL-8, we could see that the responders actually increased by the 3 months period, but it reduced by the 6 months period, and the non-responders actually increased by about double. So the non-responders actually doubled. Now, coming to IP10, again, you can see that there is a slight increase in the responders, whereas there is a more increase in the non-responders. MCP1 was more significant because you can see that the responders there was a reduction, whereas in the non-responders, actually it remained very high. And VEGF, as I told you before, this is a cytokine bead array. We had done VEGF in 2 techniques, cytokine bead array as well as ELISA, and both had shown that in non-responders, the VEGF levels were significantly lower. So now coming to each of those significant things like IL-6, you can see that this is the increase in the IL-6 between the responder and the non-responder. The non-responder's IL-6 levels were very high. This is again the IL-8. You can see that the non-responder IL-8 levels were very high by the 3rd month, which reduced slightly by the 6th month. IP10, you can see that there is a slight increase in IP10 on the non-responder group, whereas MCP1 showed a significant difference between responder and non-responders. This is a 2D electrophoresis of responders, pooled aqueous versus non-responders, and we found out some areas where there was a difference. And this is now we are going to do mass spectroscopy to find out or identify the proteins. So the levels of VEGF are reduced in both responders and non-responders. What does it tell us? Non-response is not linked to the VEGF levels per se. A small subgroup of patients definitely exists with very high levels of VEGF. That's about 10% of patients who had very high VEGF levels, which behaved a little different from all the other patients. The other cytokines, including IL-6, IL-8, and MCP1, will play a major role in non-response. So, in those patients, there is a significant role in corticosteroid, and alternate treatments in non-responsiveness are very important, like corticosteroids like dexamethasone and fluocinolone are significantly effective. And corticosteroid inhibits numerous inflammatory cytokines and signaling pathways. It inhibits the leukostasis and improve the integrity of the blood-retinal barrier. And dexamethasone and fluocinolone, astenide, maybe they are approved for the treatment of DME as well right now. So to conclude, reasons for variability in responses to treatment are not completely understood, even though we had a insight into it. VEGF polymorphisms may regulate the response to anti-VEGF treatment, and there is a need for alternate signaling mechanisms and protein candidates to identify responders and non-responders earlier. So inflammatory cascades should be curtailed by inhibiting cytokines, chemokines, and other molecular mediators of diabetic macular edema, and studies should be conducted to evaluate the prognosis of patients with DME by monitoring cytokine levels, which may pave the way for individualized or precision medicine. Thank you very much.
Thank you very much, Gopal. And that was really an excellent introduction to cytokines and its roles, especially for refractory diabetic macular edema. And I believe you will share my experience that we do face this problem significantly in the clinic. And it is often a big dilemma for us how to manage diabetic macular edema, or indeed to identify which patients are likely to need more than anti-VEGF treatment. And we will explore this issue a little later on during the Q&A. And before I go on to the next talk, I just want to remind the audience that you are free to submit your questions anytime during any of the talks into the Q&A box. So please remember to submit your questions. I will then have compile the questions at the end of all the talks, and we will have the panel answer your questions. Now, I'd like to introduce our next speaker, Jay Chablani, who will be speaking on the diagnostic revolution. And Jay is the vitreoretinal specialist at the University of Pittsburgh Eye Center in the US. And he's a good friend and colleague. We have collaborated many times. And I want to warmly welcome him to this seminar. So, Jay, please tell us what is the diagnostic revolution? Jay?
Thanks, Adrian. Thank you so much. At the outset, I would like to thank Allergan for giving me the opportunity to discuss the diagnostic revolution in diabetic macular edema. The best part is that I'm speaking third. By now, Rajiv and Gopal has set the stage, and now we will take the learning from their talks into our clinic. So let's start. These are my financial disclosure, and as you can see that I am a consultant for Allergan, an ABB company. So this audience does not need the definition for diabetic macular edema. We all know how to diagnose diabetic macular edema, but some of the key findings which I wanted to bring out when you examine the patient or when you're looking at the color fundus photograph. When I see a diabetic macular edema patient, I always look for whether do they have a predominance of hard exudates, are there any succinate, how much is the fovea involvement, or these hard exudates are how close to the fovea. In addition to that, I would look for any irmas or any neovascularization closer to the posterior pole or in the periphery. So these are some of the tips which I always make sure that I discuss with the patient, that these are the findings which I'm seeing, and then now we will be jumping onto the imaging modalities. So let's start with OCT, and OCT, as we all know, has become a standard of imaging tool for diagnosing, managing, and following up our patients. Let's look at this OCT, and you can see that we have brought 3 scans from the same eye, and these are the 3 scans. Let's start looking at these different scans and what do we see and what are our findings. So we have retinal thickening, we can see that. And then we have detached posterior hyaloid. We have some preretinal hyperreflective blurring. Then we have subfoveal neurosensory detachment. And then we have microaneurysm, as you can see here on the orange circle on the bottommost image. And then you have hard exudates, as you can see on these multiple scans, particularly I have pointed out with a purple arrow at the bottom scan. And then you have hyperreflective dots, which are shown as yellow in the middle in almost all the scans. We are going to talk more in detail about these important biomarkers. Then you have focal changes in the reflectivity. Then you have cystoid spaces. I would just go a little deeper into the cystoid spaces, because when you see cystoid spaces, you would like to know their location, their size, and most important is their reflectivity within the cystoid space. Because now we call this as SPIM, suspended particulate matter in the cystoid fluid, and sometimes this is because of the thick protein content of the cystoid fluid. Let's move forward. When you really look at a scan, one of the first things which we all should be looking at is the tractional component. If you look at this image, you are seeing that the posterior hyaloid is attached. It is not detached. It is causing probably some form of traction, but this traction is still not that obvious. We might call this as a vitreomacular adhesion. But if you look at this scan, you are seeing that this hyaloid phase is actually causing tractional component is very important in this patient. And why this is important is because this is going to limit your treatment outcome, and you might have to consider a surgical intervention at a very early stage of the treatment. Let's look at hyperreflective foci. As Gopal mentioned in detail, that there is inflammation in diabetic macular edema, and we believe that hyperreflective foci are the markers for inflammatory damage. These hyperreflective foci are seen in macular edema because of associated with retinal vein occlusion, as well as you might see these hyperreflective foci in wet AMD, but in those patients, you will have these foci primarily in the outer retina. Hyperreflective foci, if they are marker of inflammatory damage, then definitely the dexamethasone or the steroid plays an important role. And this was published in one of the recent papers in 2019, where they showed that these hyperreflective spots are responded well to dexamethasone implant in these patients with diabetic macular edema. In one of our papers in 2018, we also reported, in addition to the hyperreflective foci, you had submacular fluid, and ISOS junction also played a role. What are these hyperreflective foci on the histopathological pictures? This paper from Zhang et al. In 2008 showed that if you look carefully, the arrows and the arrowheads which show the hyperreflective foci, which are considered as activated microglia, which gets accumulated under the retina, and these are related to the inflammatory biomarkers in the retina. This is where the role of hyperreflective foci as inflammatory biomarkers plays a very important role in diabetic macular edema. What about this picture? If you look carefully, you are seeing that there are some hyperreflective dots which are seen here, which are shown on the with the yellow arrow. But these are not hyperreflective foci. They are primarily the cross-sectional visualization of the intermediate and deep capillary plexuses, which we are able to see even on the structural OCT. So do not get confused by calling these as hyperreflective foci. We already went through how do they actually look. And these hyperreflective spots which are shown here, they are not signs of inflammatory foci, but they are just a cross-section of the deep capillary and intermediate plexus. What about the focal changes in reflectivity? If you look carefully at this scan, you are seeing that these yellow arrows are showing the reflectivity has changed in these spots. What does this signify? Let's look at the same scan after 3 months. You are seeing that there is thinning, the edema has resolved, and now you can see that there is focal thinning at the spots corresponding to the areas where there was altered reflectivity. If you look at the OCT angio of this patient, you will see that this shows a massive ischemia, which you can see as the non-perfusion on the both superficial as well as deep capillary plexus scans. Why it is important to look for drill? What is drill? Drill is disorganization of inner retinal layers. Before I really get onto this, I would like to show you that before we really look at the scans, we have to see that whether you are able to differentiate layers clearly or not, as shown on these green lines. But if you look at the area adjacent to it, which is shown in a block, you are not able to differentiate these different layers, and this is what is called as drill. And drill has been shown to correlate with the visual outcome in these patients with diabetic macular edema. What is disorganization of outer retinal layers? If you look carefully, you are seeing that there is no EZ on this scan, and there is no ELM on at just above the ISOS where it was supposed to be. So you are missing the external limiting membrane as well as the ISOS junction in this patient, and this is what we call it as disorganization of outer retinal layers. And this also has been shown to be involved in the visual prognosis of these patients with diabetic macular edema. Let's move on to functional OCT. What is the role of OCT angio nowadays in diabetic macular edema? By using OCT angio, you are able to see these focal macular perfusion impairment. Do not get confused this as as a massive ischemia because these are pretty much non-confluent areas without decorrelation signal. This could be some of the earliest signs of diabetic macular edema in these patients. What else do we see? We see hypointense intraretinal spaces, as you can see here. You will be able to see some shunting vessels as shown with yellow arrows, or you will have focal dilation and the tortuous vessels as shown by the red arrows. Overall, let's look at how OCT angio is helping us, not by replacing fluorescein angiography, but it does give us a good view of the vascular changes which happen in diabetic macular edema. Let's focus on this fluorescein angiography and look at the disc. What do we see on the disc when we do an OCT angio? We can see some vascular abnormalities if you focus on the NFL-INL slab, but if you look at the VR interface, you are able to clearly see that this disc had neovascularization of the disc, which is clearly seen on these VR interface scan. And if you move forward and look at the cross-sectional B scan, you are able to see some vascular signal coming at the VR interface or the membrane, which is just above the retina. So this definitely shows that OCT angio can be useful in looking at the neovascularization as well. But be careful because OCT angio can come with multiple artifacts, particularly in DME. Here you can see that how these cystoid spaces are showing the vascular signal, which we understand that it could be an artifact. So there are no blood vessels in the walls of the cystoid spaces, particularly in this case because this is within the foveal avascular zone. But the color flow density map will show you the low level of flow, as you can see on the picture on the right, which clearly shows that this could just be because of the artifact, and this artifact primarily happens because of the small displacement between the repeated B scan, and that is where you get the false decorrelation signal. With this, I would like to conclude and explain to you that the structural OCT has become the standard practice for imaging diabetic macular edema and its response to treatment. A comprehensive qualitative assessment of different biomarkers guides treatment decision. OCT angio is a useful imaging modality for detecting diabetic-induced focal vascular impairment in retinal layers and retinal neovascularization. Overall, the imaging helps to provide prognostic signs and guide for therapeutic approaches. With this, I would like to acknowledge my friend Marco, who helped me with this presentation. Thank you so much for your attention. Have a great day ahead.
And that was a great talk. Thank you very much, Jay. And as always, I learn so much when I listen to you. You must admit that OCT really has been the game changer for us in medical retina. There is a lot more that we can do with it. And it's really important to recognize these OCT biomarkers. And looking ahead, we will want to look carefully at the role of OCT angiography as a functional type of OCT as well. So thanks very much for that. Before we move on, I just want to remind the audience, please remember to submit your questions as they pop into your head. So just push them into the question box and we will take them at the end of this session. Next, again, it's my privilege and honor to introduce my good friend and colleague, Anat Lowenstein. We've been working together for so long on many projects, and we've spoken together at many conferences. And she really does not need much introduction. She is a professor of ophthalmology and vice dean of the Faculty of Medicine at the Sidney Fox Chair of Ophthalmology at the Sackler Faculty of Medicine at the Tel Aviv University, and also the chairman of the Division of Ophthalmology at the Tel Aviv Medical Center. And it's a great pleasure for me to welcome Anat. Thank you for speaking, and please go ahead. She will speak on artificial learning in diabetic retinopathy, something that everyone is talking about. Anat?
Hi, thank you very much, Adrian. It is a pleasure to speak here under your leadership in this meeting. I think, as you said, the issue of diabetic retinopathy, I think, is the most important one nowadays. As we solve many other things, there are still many things that still need to be solved, specifically in diabetic retinopathy and diabetic macular edema. And it's a pleasure to also listen to all the other speakers and learn a lot, exactly like you said. Hopefully, we'll see each other live in the next meeting. So when I came to prepare this talk about artificial learning in diabetic retinopathy, I was actually surprised because there is not so much as about artificial learning in diabetic retinopathy, especially when you compare it to what we have about macular degeneration. There is still a lot to learn. Before I start, these are my financial disclosures. And what I said just now is really surprising because we know that the incidence of the disease and the prevalence are increasing and projected to be so high in 2045, just as an example. It's really like a pandemic in the world. So you would think that there is so many patients, so much data, that there is so much to say about it. Even though we do have some treatments for the disease, there is still a significant unmet need. So we know that even though that we are examining many patients with diabetes, in some countries there are different modes for this screening. For example, in my country, it's a quality control for the family physician to send the patient for diabetic retinopathy screening. However, there is still insufficient screening around the world, and this has been shown by many studies. And this causes the development of diabetic retinopathy. Diabetic retinopathy is known to be considered with a very high economic burden, not only of the treatments, but we are treating patients that are still in the workforce. And we know that because of lack of screening and the fact that we are seeing them at a very advanced stage of their disease is also a matter of cost to the society. So it's really important, it's an epidemic, the number is increasing. The complications are the leading cause of blindness among relatively young people all over the world. The disease is preventable by good control, and it is not totally preventable, but to a very high extent. And it's treatable, especially when it is found early. We know that the most important thing is to find the disease early. All the guidelines from all over the world indicate that all people with diabetes should be screened diagnosis. It's true that in patients with type 1 disease, it's not necessary to do it immediately, but as a general rule, and especially for type 2, you do need to examine them exactly at the time of diagnosis because they might have edema. And why do we even want to examine them so early at the beginning of their disease? The reason is that we want to see the patients when they have achieved this situation and when they still don't have significant disease, as compared to situations like this where we already have a significant fibrosis. And I would like to thank Matthias Iglici for giving me these beautiful pictures. Showing that sometimes we are also seeing patients when they are at this stage of already total fibrosis and retinal detachment, where there is very little we can do. This is a surgery done by Matthias. You will see it's a nice surgery. I'm just showing you to show that we can operate on these patients, but definitely we would like to find them and treat them prior to the occurrence of these situations. Unfortunately, there is a high percentage patients that still are lacking access to any medical care. So what happens today with diabetes and diabetic retinopathy is not effective enough. There are not enough screening programs worldwide, especially in developing countries, despite that there is increasing evidence that they are very effective. And probably a more holistic, cost-effective approach is required. We know that diabetic macular edema is a very common reason for clinic visits, and it requires costly interventions, a lot of intravitreal injections. So theoretically, if we could find it early and prevent the need of so many injections, it would be beneficial. So theoretically, if we could combine artificial intelligence with telemedicine, we could provide an efficient and acceptable standard of care for our patients. It will help ophthalmologists diagnose the disease already at the community level, prevent deterioration by sending them for early therapy, and it can help the ophthalmologist by to facilitate the clinical decisions also on tertiary referral center. So this is just to show how the numbers are evolving, and so there are so many diabetes patients, 400 million projected to be in 2030. They'll have mild diabetic retinopathy that can be treated by the primary care physician. They'll have a more severe disease with diabetic macular edema, and they will have a vision impairment. And we would like to try and prevent this occurrence by screening patients early and treating them early. So how can we use AI? We could differentiate between patients that can be managed by their primary care physician and patients who require tertiary referral centers, such as one good example is the IDX in the United States that just says if the patient needs referral or not. This is already a use of AI that can be helpful. It can also help us optimize the treatment for severe diabetic retinopathy. And we know that in cases such as happened during the pandemic and after and until now, they can help and help us choose the patients that really need to come to be examined and treated by the tertiary referral center, as compared to patients that can be treated or managed without coming to the tertiary referral center. It will also avoid the overpopulation in the clinic. So what we are thinking, what I'm referring to is the issue of deep learning that looks at the data and the output and also provides a program for the patient, what actually needs to be done by the patient, if he needs to be referred or does not need to be referred, and what else needs to be done with the patient. So there are AI models that have been approved by different regulatory agencies, and this is what I'm referring to by the IDX, which is actually the first telemedicine management that was approved ever for the whole body, and it's automated. It can tell us if to refer the patients or not. Now we are talking about a model that can predict diabetic retinopathy and enable actually the personalized treatment and prioritization of care. There is a big study that was published just recently in February of 2021 that looked at diagnosis and detection of diabetic retinopathy from ultra-wide field scanning laser ophthalmoscope images in a study that we've participated in, and there is another study that looked at that. But in any event, we were able to show that it is possible to detect the images and to use AI for deep learning analysis and to see what needs to be done with the patients. So the issue here is to use ultra-wide field imaging as compared to single or two field 45 to 50 retinal photographs, which can be done in the primary care setting. And of course, when you do an ultrafield, you have a much more data, but it requires expertise. So in our study, a novel model of deep learning was developed to detect the gradability and to assess the detection of both referable and vision-threatening diabetic retinopathy. The referable was anything that was more than moderate, and treatable, anything that vision-threatening, any presence of diabetic macular edema, severe NPDR, or of course PDR. And we tried to assess the gradability to evaluate the presence or absence of referable diabetic retinopathy, vision-threatening diabetic retinopathy, and all of this used deep learning models. These are just some very, very beautiful examples, images that can be shown. And as you can see from the area under the curve, under the receiver operating characteristic curve, you can see that the results are excellent with a very good detection rate in this regard. And the ratio of sensitivity, specificity, and positive and negative, positive predictive value and accuracy were very high for everything, for referable diabetic retinopathy, for vision-threatening diabetic retinopathy. It was all around 90 or higher than 90. So it seems that using teleophthalmology and the deep learning system, we can achieve a goal that can really help patients with diabetic retinopathy all over the world. And I think it is a very, very important point nowadays. So acknowledging that what we do now for diabetic retinopathy care on a large scale, I'm not talking about particular patients or particular populations, but on a large scale, it's definitely insufficient. Artificial intelligence based or using screening models can decrease the cost and it can be of lower cost and be more productive. If it is fully automated, it can actually enable ophthalmic care to be differentiated between different populations. So really to refer to the tertiary referral centers only the patients that need such referral as compared to seeing everyone. We would like to see everyone, but it's not always possible. And it's theoretically it can be used in a very wide geographic area distribution, and probably it is cost effective, as has been shown for other systems. So I would like to thank very much Matthias Iglici and Dina Tsur and the other participants of the study, and also by helping me to prepare the talk and sending me all these beautiful images. And I look forward for your questions during the discussion time.
It was great, and thank you very much, Anurag. You have really raised a very, very important issue for us, using technology to help us reach more and more diabetics throughout the world. And I'm really talking about those who have largely inaccessibility to care, those in rural areas, those in developing countries. And I think this is such an exciting way for us to be able to reduce blindness. And certainly it will dominate ophthalmology, in particular diabetic retinopathy screening, as well as management in the years to come. And we will have time, hopefully, at the end to discuss some of the practical aspects. Next, it's my pleasure to introduce our next speaker, Professor Shobha Sivaprasad. She is medical retina consultant, ophthalmologist at the Moorfields Eye Hospital, NHS Foundation Trust, and also professor in retinal clinical research at the University College London. And she will speak on diabetic retinopathy screening in this year, 2021. So Shobha, thank you for joining us, and please enlighten us.
Thank you, Adrian. So I'll go on to my financial disclosures first before I start my talk. So I'm just going to give a summary of all what that was discussed from the beginning up to Anat's talk on AI, because as we can summarize, about 10% of the adult population in the world have diabetes, and a third of them have diabetic retinopathy. So if you consider that is approximately equal to about 28 million people in the world with vision-threatening diabetic retinopathy, 17 million with proliferative diabetic retinopathy, and 20.6 million with diabetic macular edema globally. So It is an incredible challenge around the world, and Anat just mentioned how care shows massive variations, with many parts of the world having no access to our almost inefficient way of monitoring our patients for development of sight-threatening disease. Most importantly, out of the 20.6 million people with diabetic macular edema, only 63% of patients have visual impairment. So you can see that already in the epidemiological studies, you see a structure vision dissociation. When we go through the impact of COVID-19 pandemic, I'm clearly bringing this out to show how the COVID-19 actually helped us reflect on the way we provide diabetic retinopathy care in the world. So the people with chronic diseases, especially diabetes, was severely affected during COVID-19 pandemic because the access to care was limited and people feared leaving their homes. There was government restrictions and lockdown, for example, that prevented access, and also patients decided not to go out for fear of getting the disease. And this resulted in a reduction in the number of patients seen in clinics, especially because we were advised social distancing as well. All these led to a great number of patients not getting their care in time, patients suffering from mental health problems, and of course, all diabetic retinopathy screening programs were suspended for a considerable period of time. All this made us think, what is happening here? How can we ever recover? How can we provide better access to diabetic retinopathy screening around the world? Coming back to the numbers, if we are to provide annual diabetic retinopathy screening to 422 million people today with diabetes, we know that is not possible. Trying to cross that hurdle by providing more cameras is not the answer, because there is no resources, no human expertise, no infrastructure, and not even enough treatment facilities for our patients. So one way out is to identify people at high risk of developing sight-threatening disease. That is longer duration of diabetes. That means prevention programs for diabetes should be encouraged. And of course, all the earlier speakers mentioned about how hyperglycemia, hypertension, and hyperlipidemia are modifiable risk factors. So there should be a massive campaign in preventing diabetes so that we prevent vision-threatening diabetic retinopathy. While saying that, Anat clearly told us that hyperglycemia may not be the only answer. So we do need to find out ways of triaging patients with risk of sight-threatening disease from the 422 million people with diabetes today, which that number is only going to increase. So we need to develop risk models that will accurately identify these patients. Artificial intelligence and of course telemedicine is a way forward, but to improve efficiency and productivity in the way we screen patients, we need to find out who are the high-risk patients. Can they have preventative programs fast-tracked to them to get their care? So what have we learned from routine screening for diabetic retinopathy to date? Firstly, we know diabetic retinopathy is an asymptomatic disease in most patients. Even eyes with diabetic macular edema may be asymptomatic in the early stage or even in the late stage. Practitioners and patient education is crucial so that we involve patients. And then non-mydriatic screening shows that a considerable portion may have ungradable images because the pupils are not dilated sufficiently. And the systematic way of screening diabetic retinopathy patients should be mydriatic to avoid technical failures. And Anat just showed us about how wide field screening should be the way forward. This again gives us more complexity, but actually more accuracy in identifying these patients. All these suggest that actually diabetic retinopathy screening as it's run today is very complex. It needs expensive cameras. It needs expertise from humans to deliver it. So some ways of of solving this problem is what all our earlier speakers mentioned, and that is better imaging using skilled screeners and better grading using artificial intelligence. And then for costly cameras, we do now have cheaper smartphone type cameras that could be used. So we are improving. But what did COVID actually accelerate our progression into understanding how to deliver diabetic retinopathy screening is that we managed to understand that telemedicine is the way forward. We also know that AI will be an efficient and productive way of delivering diabetic retinopathy screening in the community. And we also know that AI can replace some of the human graders wherever possible. These are all very positive news. However, we do need validation of these programs. We need to ensure that whatever we deliver is safe for our patients. And we need to ensure that mydriasis has to be done for these patients. So there is some more work to go on in globally, but whatever said and done, I believe we are in the right track. We are in a fast-paced track now, and there are several societies around the world, like the International Diabetes Federation, WHO, etc., who are now realizing that diabetic retinopathy screening should be prioritized to decrease the risk of blindness in people with diabetes. What about home monitoring? So far I've said that we need imaging, we need AI, and we need humans to examine these patients. But what about home monitoring? So I just brought up the Draco study, which was a recent study done across over 35 centers in the UK, looking at new and treated diabetic macular edema patients. And what this graph shows is that patients present early, you can see a large number of patients with more than 69 letters, that is 70 letters or better, presenting to the eye clinic. This may be because we have a very good screening program. But what is more important is look at the central subfield thickness. There is no correlation between visual acuity and central subfield thickness. If at all there is a relation, it is very modest. So if we tend to home monitor our patients to diagnose or monitor diabetic macular edema using visual acuity, we are in the wrong track, because structural changes in diabetic macular edema will precede visual acuity changes, unlike macular degeneration, where there may be a better rule. What about the age group at which these patients present? Again, majority of the patients are aged 50 years or above, with very little technical knowledge on how to use home apps to look after their eyes. So we are far behind in thinking that our patients will be able to grasp technology and run with it. We are here, we need to provide their imaging and AI and telemedicine, etc., to provide them with care rather than think of visual acuity related apps. Of course, if one could deliver a home monitoring OCT, that would have helped diabetic macular edema than any other new gadgets. So in conclusion, what I would like to say is we do need to screen every patient with diabetes annually. However, the current screening program is not feasible, and therefore new techniques should be developed, and telemedicine and AI is definitely a very good way forward. We do not believe home monitoring with visual acuity is a way forward, because patients with proliferative diabetic retinopathy will not even realize they have this disease. Patients with macular edema will not have any visual acuity symptoms for a while. So we believe telehealth is a good resource for improving coverage globally. And we hope that AI can be integrated into telehealth programs to ensure that the whole globe of people with diabetes will get annual or at least regular diabetic retinopathy screening. Thank you.
Thank you very much, Shobha. And I think you have given us a timely reminder of some of the challenges as well as the barriers to an effective and globally reaching diabetic retinopathy screening program. I like the points that you raised in particular that we must not just use visual acuity as a form of home monitoring. And ultimately, I guess we will need maybe a cheaper, more effective way, such as home based OCT, perhaps, as a form of monitoring for home based monitoring of diabetic retinopathy. But thank you very much, Shobha, and we will have some time in this coming session to discuss some of these issues. So we've come now to the panel discussion. I want to thank all the speakers for your excellent presentations and also keeping on time so that we have enough time now to devote to answering the audience's questions as well as having a discussion of the major points. I just want to invite all of you to put on your videos. Joanna, if you can come on as well, that would be great. And we already have been receiving some very nice questions from around the world. But before we get to a few questions, I just wanted to ask a few questions. Maybe we'll start with Rajiv. You mentioned the gut microbiome, and I think this is really a growing area of interest, not just for ophthalmology, obviously. I mean, we hear now of the role of gut microbiome in many diseases. How do you think this might have therapeutic implications for DME?
It's already started. There have been some animal work suggesting the role of intermittent fasting in diabetic retinopathy, especially work done by Dr. Maria Grant. But these are all animal studies, so probably we will see a role of altering the gut microbiome by intermittent fasting or fecal transplant or probably probiotics, which may play a role. If we alter this gut microbiome, probably the development of sight-threatening retinopathy in future may reduce, but that's something in coming years we'll know. But as you rightly said, already it has come to therapeutics in many of the autoimmune diseases, even cardiovascular diseases. I'm sure in these microangiopathy, there will be a role which should be gradually, we'll see how it comes to a therapeutic area.
Right. Thanks very much, Rajiv. And I think obviously we have to watch this space and we'll have much more work to come. Both you and Gopal actually mentioned the role of cytokines, which is really important in the pathophysiology of DME, both responders as well as non-responders. I have a question here for Gopal. That is, do you think that, clinically we will be able to use cytokine measurements to determine which patients are likely to be non-responders to anti-VEGF? Will this, you think, be clinically available in the near future?
Yeah, excellent question, sir. So, what we require is a huge data of number of non-responders. When I had 40 patients, there were about 10 non-responders in it. But what we should be looking for is about 1,000 non-responders across the world, and look at the cytokine profile and come up with smart. Then only we will be able to get good evidence and good statistical significance to say that if you have this cytokine at baseline, you are probably going to be a non-responder. So I think the key is increase the number, pool the numbers, and do more of these and get the results out.
As a follow-on to that, do you foresee that there will be non-invasive ways of determining cytokine levels in the eye?
I think that we have to have OCT biomarkers or any other imaging biomarkers which can reflect the change in cytokines or the baseline cytokines within the eye. So I had done a little bit of work on that, but again the numbers are too small to actually bring in a statistical significance to that. Like for example, the outer, like if you have cystoid edema versus submacular fluid versus hard exudate plaque, how would the cytokines be inside the eye? What about the outer retinal damage, if it is there? Then how would it reflect onto the cytokines? So these studies are done, but again, definitely these are there are significant indicators to that. And I think pooling of more data, increasing the data volume will definitely get us to that. And I'm sure that in about next 3-4 years, we will get that.
Absolutely. Thank you. Anat first, and then maybe Rajiv.
I wanted to add something. I think that the issue of taking cytokines from within the eye is always problematic. First of all, we don't want to, it's a difficult thing to do for the patients that are just being screened to find biomarkers. Of course, we could do it when we're doing vitrectomies, but this is already a very late stage of the disease. And I always ask myself how much we can gain from that. It seems to me that I heard the talk, and I'm very impressed, and I know about the biomarkers. But I think a very important biomarker, and sorry, I'm pushing to my talk, is baseline visual acuity. I think over the years, this is the most important biomarker. It's funny to say, but it's as though when you have a good visual acuity, nothing else matters. Like when you have drusen, nothing else matters for AMD, no genetics. So I think this emphasizes the fact that we need a good visual acuity as a biomarker, and therefore the screening is so important and all the models that we talked about. I'm
Thanks,
not,
Anat.
lowering anything that you said, but and I realize that it is important, but I'm just saying that since it's difficult to take the cytokines, especially at the early stages, because you don't want to turn the patient's a surgical procedure. Yeah.
Okay, good point. Thanks. I agree with you. Rajiv?
Just wanted to add 2 points. Like one is, as you rightly said, as Dr. Annette said, it's difficult to take the fluid, but sometimes what we showed is that with a vitreous reflux, when you are giving injection and whatever is coming out, you take it in a Shermer strip and try to measure cytokines in that. Still, it is difficult because it is so variable, the amount of VEGF or any other cytokines. We don't have any normative data. We don't know what is normal, what is abnormal. That's number one. Second thing is, even from where in the eye, there is regional distribution which is different. These cytokines near the surface of the retina versus anterior hyaloid phase versus aqueous, the concentrations and the levels would be totally different. So I think coming to a therapeutic, it is very difficult that we can really use these cytokines to determine the response versus non-response. A very nice question you asked, that can we have a non-invasive way of measuring these? Unlike carotenoids, which show a typical Raman signature, which is picked up by many of these other methods, many of these cytokines cannot be picked up by optical means. We did tried looking at if we can use some of these molecular characteristics, we can measure non-invasively. But unfortunately, many of these cytokines don't show the typical signatures which can be picked up on by any optical method.
Right. Thank you very much, Rajiv. Let's turn now to the more clinical aspects of the evolving landscape for DME. And I want to just ask Jay, we have a question here from the audience. Really, what are the factors that make you think that these patients are going to will probably have more cytokine-mediated disease than VEGF disease? This is of practical importance because it helps clinicians decide how soon to switch from an anti-VEGF to perhaps a steroid treatment. So maybe you can share with us, what are your clinical biomarkers, not just on the OCT, but other aspects as well?
Yeah, thanks, Adrian. And I think Anad brought the very valid question, non-invasive way of looking at inflammation. So I believe that is where we can take some help from our in vivo imaging, which we do almost every time for our patients. So particularly when I'm examining a patient, if I see a lot of hard exudates, then I am more in favor of starting that patient on anti-inflammatory approach such as steroids. And if I'm looking at it in an OCT, and if I see that there are hyperreflective foci, which I was showing in my talk, then I will be more in favor of offering a steroid treatment. So your question was very pertaining, that when do you decide to switch? So we all have experienced that the early switch is the only way to really move forward. So if we all start our patients on anti-VEGF therapy, some of my pseudofakes I start dexamethasone implant. But most of us start our fake ache patients on anti-VEGF therapy. We all tend to switch by 3 or 4 injections. And if you're looking at those on the OCT and you look at these biomarkers such as hyperreflective dots, you understand that your patient is not responding, and these are the signs which are tending towards in favor of inflammation, and that is where the role of steroid comes in.
Mm-hmm.
Yep. All right. Thanks very much. Shobha, you have quite a lot of experience treating DME, especially difficult cases, recalcitrant or refractory cases. So how do you decide when and what to use? So presumably, if you start off with anti-VEGF therapy, what would be the biomarkers or the prognostic factors be in determining whether you switch to another form of therapy, in particular the dexamethasone implant?
Thanks, Adrian. If I knew the answer, that would be good. Actually, I don't, because we have done several amount of work on prognosticating diabetic macular edema in response to anti-VEGF. None of the markers to date, except baseline visual acuity, was a prognostic indicator. So we looked at hyperreflective foci, exudates, ischemia, you name it, subretinal detachment. Somehow none of them seems to come up in any of our work. So and even now it is still baseline visual acuity. So in routine clinical practice, we treat according to protocol. So we all have a protocol that we have to follow, and that is we have to give injections until stability is reached. That is until the amount of stability in CST, which may not always be dry macula, it may be that it's not changing anymore. Once you reach that and the visual acuity is not changing, if it is not to our satisfaction, then we can switch to steroid in a pseudophakic eye. We don't normally do it on a phakic eye. Right. The other option is to do cataracts. If the visual acuity is also due to cataract, then one way out is to do cataract surgery and an Ozurdex implant at that time. Some of those cases do pretty well. Otherwise, we actually do not have a protocol to say when to switch, because there isn't any sufficient evidence for us. Yeah.
Thanks very much, Shobha. I just wanted to ask Anat, do you have any indications for the use of Ozurdex in treatment-naive patients?
Yeah, I use Ozurdex in treatment-naive patients at a few occasions. First of all, I think, and this is actually the most common reason, is in patients that cannot or are not willing to come for monthly treatment at first. Because we all know that if you want to go to the excellent results from anti-VEGF that came out even in protocol T, you need at least 5-6 injections to start with. And if a patient says, well, I came today, I cannot come now for 3 months, and is willing to take the IOP with his family ophthalmologist, then I can say, okay, so let's start with Ozurdex. Of course, in Israel, it's a problem because Ozurdex is not approved for first line in these patients. And the second reason is, of course, a patient who is pregnant, which happens in diabetes. A third reason is a patient that just had a stroke or MI, and just is a matter of interpretation. So to me, if you had a stroke today, definitely he is eligible, and then everything is in between depending on the patient but basically I think that if it's more than a month, it's much less of a problem. Less than a month, I would try not to give an anti-VEGF agent. So patients who are not suitable or cannot come, patients who are pregnant, patients that just had a stroke or an MI.
In fact, I think you raise a very often neglected issue, which is treatment fatigue, because one can attempt to treat it with anti-VEGF ad infinitum, but there will be a finite number of injections the patient can tolerate, and if they are expected to come back on a monthly basis for 6 months or more, that will place an enormous strain on them, both socially as well as economically, as well as for families having to take care of the elderly. So I find that in Singapore, that would also be certainly a good indication for longer, more durable treatments, such as the DEX implant. I have a question for Jay. This is regarding ischemia. So, do you find the correlation between subfoveal choroidal thinning and ischemia to the outer retina?
A very interesting question. In fact, we have looked at this very question in some of our research. Unfortunately, the choroid is pretty thick, and the changes which we see on the outer retina may not really represent in terms of the choroidal thickness. But if you really look at the choriocapillary slab on the OCT angio, that might show some flowoid areas which can correlate with the outer retinal damage. Saying that, what I want to say is that structural OCT or structural thickness may not relate with the outer retinal damage in diabetic macular edema. In AMD and diseases which are progressive in terms of choroidal, which are primarily choroidal diseases. In those diseases, you will see more choroidal changes going in parallel with the outer retinal changes.
We know that sometimes we don't only see macular ischemia, but more widespread non-perfusion in diabetic retinopathy. One of the advantages of anti-VEGF, of course, is to try and reverse that ischemia as well as a downgrading of the severity of retinopathy. Do you see that this is also seen in steroid treatments such as the DEX implant? And does that help with ischemic maculopathies?
There is some there are some papers which are showing there is a downgrading of diabetic retinopathy with DEX implant. I personally have not experienced this, but the literature does support. However, the studies which are published, they are not randomized studies, so there is still some limited evidence on that. This is something very important because which we always say that if you are treating your diabetic patient with dexamethasone implant, you should always be careful that your patient may have progression of diabetic retinopathy. So similar thing which we talk about central retinal vein occlusion as well, that if you are treating an ischemic CRVO with DEX implant, you have to be careful that the VEGF, or I should say VEGF-driven changes in terms of neovascularization may still not be very well controlled with DEX implant. This was some of the criticism in a very early stage, almost a decade ago, where people were really concerned that I treated my patient with DEX implant, but the patient turned back with a neovascular glaucoma because we did not treat the VEGF-driven component in that CRVO. So I think we have to be careful. There is some literature in terms of downgrading of diabetic retinopathy, but I believe still it is a matter of concern.
Thank you. There's a question for Gopal. Is there a relationship between the level of cytokines in the eye and in the serum?
An excellent question indeed. It would be so easy to take the blood and find out. So, unfortunately, by the time there's a study by Francis Wu et al., which was published in Investigative Ophthalmology Visual Sciences last year, which looked at, in the highest level of aqueous VEGF, that's in proliferative diabetic retinopathy, was there a correlation between aqueous, vitreous, and plasma? Unfortunately, there was no correlation with aqueous and vitreous with plasma, even though there was good correlation between aqueous and vitreous. Another problem is that by the time these advanced diabetic retinopathy develops in people, they will have a lot of systemic problems as well, which will modify these cytokines. And there are some biomarkers which are there in the blood, which also correlates with retinopathy, proliferative diabetic retinopathy, and diabetic macular edema, but not these cytokines.
All right, thanks very much, Gopal. It's a shame, though. It would have been much easier if we had a serum correlation, for example. But we will just have to keep looking, I guess. I've got a question here from Dr. Samath Agrawal from India. This is directed at Shobha. How effective was the introduction of the secondary Moorfield city centers in high streets and malls and so on in the detection of vision-threatening diabetic retinopathy, and whether or not this could potentially be replicated in other parts of the world, like in India?
So we have just started it. We are validating it so that it can come out with standards for global replication. It will take at least another 12 months for that first paper to come out. But I think, Anat, there's so many people around the world who is already doing it, and telemedicine is definitely the way forward. It also depends on the health systems. For example, even in the UK, where system is free, if we are to involve the high street optometrist, etc., they are private providers. So we cannot just say you go and do screening for these patients. You need to
Of
pay them.
course, of course.
So that is a major challenge that one has to take on. So what we are doing is the secondary care providers are going out to the primary care to provide the service. And I think Shankara Netralaya, Dr. Rajiv Raman is also doing that. So you go out so that whatever you do is already charged to the hospital rather than to the primary care. But it may not be an ideal way, because end of the day, there's just too many people with diabetes. So we have to use multiple pathways to screen everyone.
Good point. Thank you very much. Yes, Anna. Sure.
I want to add something. I think, Shobha, what you said now is extremely important, because, and it's actually not only in diabetic retinopathy. I find it a lot when I'm dealing, I'm working a lot on AMD, and it's kind of telemedicine with the home OCT. There is a huge problem with the model of this managed care, combined care, because now it's not only the patient and the physician. Now it is the patient, some kind of computerized system that the patient is using, some cloud to which all the images are transferred, some AI that someone is responsible for that interprets the data, and someone to send the alert to the physician and to the patient. So who is reimbursing for that? Is it the optometrist on High Street? Is it the HMO? Is it and who pays the physician for his time to oversee all this data? All of this needs to, it will need a lot of discussion and a lot of issues. And I didn't even start to talk about liability, because let's say that the patient did not put his images on the cloud. Who is responsible for that when it comes with this proliferative disease that I showed you before? And let's say that the patient did put it on the cloud. They told him to go immediately to the hospital, but he didn't get this response, this alert. So who is in charge of this? So there are regulatory issues, reimbursement issues. It's very, very complex.
Thank you. I think you also highlighted the data protection. That is also a big issue in securing the data that you obtain on a very large scale on individuals. So I think we really have to sort through these issues carefully. I'd like to ask Rajiv, maybe you can share with us your experience in Chennai, and how do you intend to roll out a more extensive, more comprehensive screening program, perhaps in a community?
I think what Dr. Annette and Dr. Shobha told, AI is the future, and we have started using it in our hospital. So we have integrated the AI system, which is developed by Google, into our EMR. And patients who visit our hospital, to the anterior segment surgeons who are not very familiar in diagnosing diabetic retinopathy, they undergo a retinal photography, and the AI system grades and gives an alert. We use it more like an assistive mode, so that the photographs are also graded by the ophthalmologist, and then he has a chance to look at the AI grade and augment his grading if he wants to do. We also use it at a physician place, where it's a fully automated grading, because he doesn't grade the diabetic retinopathy, he just takes the images and based on AI, he refers. So I think that is the future. But as Dr. Annette rightly said, there are a lot of issues as far as data privacy and who takes the responsibility if we miss the lesions. And All India Association, our AIOS, All India Ophthalmic Association, they came out with a guideline that at least 10% of these images should be regraded by ophthalmologists, even if they are normal. So I think like these guidelines will come individual countrywide, and that will make the things pretty easy. But AI is the way it needs the future, and even American Diabetic Association guidelines have included AI for diabetic retinopathy screening into their charter, the 2021 guidelines.
Thanks, Rajiv. And Jay, you had a comment?
I just wanted to make a quick comment that yes, we are really concerned about the data protection and the security, but I believe COVID-19 has given a lot of lessons to us in addition to the vaccine. And now that the Internet of Things and blockchain cybersecurity is very much part of our AI uh, efforts. So the future is pretty bright. It's just that the data protection and the security is going to get much easier for us. And the way we are going to get connected through Internet of Things, that is called IoT, is going to help us long way. So we have a bright future.
Thanks, Jay. And I think that's a timely comment. It's good that you brought up the issue of COVID, which all of us have faced now for over a year. And with every crisis, I see opportunity. And I see that this crisis has brought about a paradigm shift in our acceptance of telemedicine and potentially acceptance of artificial intelligence, which perhaps would have been much more difficult if we did not have COVID. We have a question from the audience for Anat. In your practice, how did COVID affect outcomes for patients with diabetic retinopathy? Anat, I think you are muted.
Yeah. I apologize. So at first we were reluctant to treat them because we wanted to space out, and see as little patients as possible. So we gave priority to AMD patients. Later on, when we saw that the virus is there to stay and we need to live next to it, we started to examine them exactly. Now we're seeing all elective patients regularly. And I can tell you that I did see patients that were reluctant to come, or we postponed them and lost vision, either because they were not diagnosed or they didn't get their treatment on a timely manner. And it's not, maybe for a month they really could not come, but later on it didn't come for a month. It doesn't notice any change in vision, so it just stays at home. And for the patients who really needed treatment, we went to the homes to inject, that we did this big effort, but we did it only for AMD patients. We didn't go for DME because we wanted our resources to be as used as, as much needed as possible. So I did see patients that lost vision. Yeah, absolutely.
Yeah. And I think, certainly we have learned valuable lessons in our management of neovascular AMD, because in some ways, neovascular AMD cannot tolerate recurrence and disease activity for a long time, and we've really learned painful lessons. In neovascular AMD, we tend to treat at every visit, which is using a proactive treat and extend. Would you consider the same approach for diabetic macular edema under these conditions? I know that.
I definitely would.
Yeah.
I definitely would.
Yeah. Okay, thanks. Shobha, what is your approach during this COVID time to try and mitigate visual loss and poor outcomes due to non-attendance?
Yeah, we did exactly what Anat said. So AMD was prioritized, wet AMD was prioritized. And then for diabetic retinopathy, we only triaged all the proliferative retinopathies and advanced eye diseases. For diabetic macular edema was second step. So they only came back to have treatment 4 months after the start of COVID. We have got mixed results with patients having to wait for treatment for diabetic macular edema during COVID. Some literature is coming out from UK stating there was no impact on visual outcome for diabetic macular edema patients, while from around the world, when you look at the overarching, there are more publications stating that there is an impairment or negative consequence of waiting around, but it's mixed results. Yeah.
I agree with you. I think it depends.
Probably it just shows our structure function problem, because they may all have come back with lots of edema, but may not have affected the visual acuity, because in 4 months, maybe it's still a very benign disease in that way. If we had waited longer, maybe we would have seen disastrous complications. Yeah.
I think certainly in Southeast Asia, we are seeing an impact now of untreated or late treated diabetic macular edema because borders have been closed, patients' movement have been restricted. For example, many of my patients are stuck in Indonesia and unable to fly into Singapore for their monitoring and their treatments. So we are beginning to see quite disastrous effects in some patients. There's a question for you, Shobha, from Sri Lanka about mobile phone fundus photograph systems. Do you have any experience with them using the phone
So
for
we,
fundus?
I think what they mean is the smartphone cameras by Remedio that we tried
Yeah.
in Kerala. So it's a handheld device that can be fixed at the respective family health centers. It worked pretty well. It has now got AI incorporated in it, so it's an offline system. So if a image is captured by a family health center nurse, first click it will tell you whether the quality of the image is good enough for grading, and if it is good, okay, they can pursue with it. Otherwise they have to continue till they get a good picture, and then the image is also read instantly and it says refer or not to refer. So it's all in one package. Dr. Natarajan published its use in Mumbai, and it seems to have good sensitivity with the and specificity with the AI. I do not have the experience in doing it in a wider population with it, but definitely I know that it's being now tried in several countries around the world.
Thanks very much, Shobha. Anyone else has any experience with home-based or sort of mobile phone-based systems that can help to increase the accessibility of these imaging? Not maybe you,
I
you
have
might have had some.
I have a lot of experience with the home-based OCT, but basically most of our data is on AMD. We did do
Right.
some patients with DME, and you can do it, of course. An OCT is an OCT, and you can see it. I think it like a home monitoring for DME is less of an issue because you don't need daily examinations in DME. Even if a patient is treated, you don't necessarily need daily examinations. There is a model for it, but it's not elaborated enough yet. I guess it's possible and it can be important, but I think the whole model needs to be different because they don't need as frequent examinations as the AMD model. And for the AMD, you need a daily examination for the statistical analysis that the system is doing all the time.
Yes, I agree. So I think maybe we are still some way off to a fully automated AI system. I think it will probably still remain a hybrid. Let me just conclude this session by going around to the panelists. I just want you to perhaps each of you give us a thought about what the immediate near future will be like for DME management and your hopes for this problem. Maybe we start with Rajiv.
Yeah, I think it's been really a great session, and two things which emerged out of this is one is COVID is not to go now, and teleconsultations and AI are the future. Definitely, in next couple of years, we'll see. And as Dr. Annette said, it's not only the diagnosis or a screening, the predictive power of AI will come where we can probably even think of predict whether the patient will respond to the therapy, whether how frequently we need to follow the prediction regarding the progression of retinopathy. I think these are something the technology has really changed. Like I always give an example that a couple of years back we could never have thought that it was only physical money. Now we do many of the transactions by our phone. So how the it has become a digital money. So I think the technology is changing very very quickly, and next couple of years are exciting, and we will see AI entering into our the way we treat diabetic retinopathy in a big way.
Thanks, Rajiv. And also, public acceptance is also growing. Gopal, what are
Yeah.
your wishes or what is your prediction for the near future for DME?
Yeah, I think more than any cytokine or invasive predators, it would be an individual, probably a mobile based retina selfie. So you can take a self picture, probably it goes to the cloud, get the basic diagnosis, tells the back whether you have to be referred to a doctor or you can sit at home. Some sort of a model that would widen the net and basically catch more of these patients much more earlier, which will basically, so transfer of technology to this, to the last person is what I think would happen in the next couple of years or maybe 3 years.
So no longer the stuff of science fiction movies. It might well be reality. Jay, what are your parting thoughts to share with us? You're muted, Jay.
Sorry. So I'll just take forward Rajiv's thought and say that the future is crypto. So the blockchain is future. So blockchain is future, and we will be taking the selfie of the retina, and it will all be secured and diagnosed by AI. So I think future is super great.
Great. Thank you for that optimistic hope. Anat, what are your thoughts on
Well,
the future?
I am a little more realistic. Of course, I want a cell phone to tell me everything, but I think it will not happen today. There are many issues with the use of cell phones in this situation to give a good answer and many things. But I think that a screening model that will include OCT would be extremely important, because all we do now is screen for diabetic retinopathy, because we cannot really say, I cannot really say if there is edema from looking at a wide field image or even at a 35-50 degrees image. I don't know, Adrian, maybe a few people can, but I cannot. If I think of someone who can, it's maybe you, Michaela, Susan Bressler, one of the three of you, but maybe Shoba. But I'm not comfortable with myself to see it, not even clinically, let alone with images. So I would like a screening tool that will include an OCT.
Great. I share that wish too. And Shoba, I
have to end, so I don't want to end in a pessimistic note, but I should say we should be optimistic about the screening aspect. I think we will find more and more patients with diabetic macular edema from around the world with various gadgets. But our biggest challenge is to get them treated, because they don't understand they need treatment. And there is a big gap between identifying these patients and treating them. And then once they come into treatment, our treatments are just too much, too long, and we don't get the outcome we want. So it is a long way off. I think I don't want to be pessimistic, but we have to be realistic. And I think there are lots more to do. We are not going off as a profession, I can tell you that.
Thanks very much, Shoba. I'm a glass half full sort of person, and I think we've got lots more to offer. But let's go back to the original theme where we looked at the evolution of DME, and my goodness, where we've come from the old days, the dark days of focal grid laser and so on, nothing that could be done for diabetic macular edema, to now. And here we are talking about refinements and bringing this to a different level. My wish for DME is really a longer, more sustained delivery, safer treatments, more effective against non-responders. And I think we are actually well on the road to doing that. And I share all your views. I want to thank all of you for all your expertise, as well as your thoughts on this subject. It's been really fascinating to hear your talks as well as the discussion. But this is all the time that we have at the moment. I want to thank the audience for so actively participating and submitting your questions as well. I'd like to now just hand over to Joanna Gonzalez to close this session. So, Joanna?
Thank you very much, Dr. Ko. And just as you have said, I would like to thank the faculty for the excellent presentations and the very interesting panel discussion, and of course our audience for joining from various countries. And please remember to submit your feedback through the feedback button on the right side hand of your screen. It is very important for us, and we are looking forward to having many more Retina sessions with topics of your interest. So it's a thank you from me as well, and have a good night.
Thank you so much.